Vivek for kind introduction. The topic which has been given to me is current management. The diabetes is a complete, use the word topic in itself. Squeezing it in 10 12 minutes is not an easy task. But I thought let me pick up some highlights which can just guide us. Or what are the management principles of diabetes? Who is at risk of what type of diabetes? So, ADA brings out these circulars from time to time. This is one such pamphlet which tells you have to do a risk stratification in every patient. How old are you? Are you a man or a woman? If you have had gestational diabetes, you have a family history, you may have blood pressure, morbidity, are you physically active? What is your weight category? These are some of the risk factors which one has to see before you look at diabetes and how to manage diabetes in a patient. And ultimately, in whatever case of diabetes you might have, whether type 1 diabetes or type 2 diabetes or gestational diabetes, ultimately the bottom line is lifestyle modifications. And lifestyle modifications, we know traditionally include diet, exercise, and along with that probably come drugs. And the drugs, when we talk about, we're talking about either oral hypoglycemic agents or insulins, or like you're having a hybrid combination of both. And ultimately, what is our aim? Our aim is that a patient's sugars should be within normal limit without the risk of hypoglycemia and preventing the complications which are associated with diabetes. And now with a lot of emphasis on bariatric surgery also, which Dr. Prof will guide us as always. And that will also be an integral part of treatment of diabetes in the future. The diet has to be patient-centered. Those days of giving patient a diet chart, having a 1600 calories chart or 2000 calorie chart is over. Now a person has to be asked for what kind of a diet you take, and depending on that, you kind of titrate that diet which is useful for him. For example, telling a North Indian to have upma and idli or 200 grams of poha every day might be very difficult. But if you tell them to decrease chapatis from 3 to 2, or rice from a full bowl to half a bowl, is still possible. And ultimately, as a clinician, we should look for at least 7% weight reduction in a patient and try to have as much normal weight as much as possible. Exercise is an integral part of any management. A young patient should be encouraged to do at least 60 minutes per day. And if you're a girl, then it is defined as at least 150 minutes per week without a break of a day or more. After at least 3 to 4 days of exercise. And all these things like aerobics or yoga or tai chi, they are useful. They do contribute towards exercise, but ultimately walking remains the easiest thing to do for most of our patients. Oral hypoglycemic drugs we all are familiar with, and if you look at the latest, now this is a chart which has been picked up from the 2023 guidelines, which have just been released by ADA. This is a complete chart which tells you how to use diabetic drugs, in which patients, etc. And if you look at the major headings, after the patient's lifestyle, you look at whether the patient has a heart condition, whether the patient has a heart failure, whether the patient has a CKD. In all these cases, different drugs are used in a different way, and some have been proven to be more useful. And ultimately, like I said, our goal is to have a normal diet, normal sugars without hypoglycemia, and probably preventing complications in most of the patients. And if, of course, you are not able to control with oral hypoglycemic agent, then insulin remains an option all the time. This is another master chart which has been taken from the same 2023 guidelines, which can be downloaded by everybody. And you can see the list of drugs which are available to us. When I started practice in 1990, we used to have only 2 drugs available. One is bigonides and sulfonylureas. And now we have at least 7 to 8 groups, like SGLT2 inhibitors, GLP-1 analogs, DPP-4 inhibitors, thiazolidinediones, along with alpha-glucosidase inhibitors and all. So the advantages, the pros, the cons, they all have been listed in the master chart. And I think most of the clinicians are familiar with this. I think in 10 minutes we can't squeeze in everything. But SGLT2 inhibitors and GLP-1 analogs have become more and more popular. And lately, since they have become more economical for most of us, so I think we can use it almost in all our patients nowadays.
It's going up, And these patients are ending up with the low ejection fraction. There are two types of heart failure. One is the reserved ejection fraction, another is the low ejection fraction. We will have some pacemaker session. So thank you very much. Dr. Das, please go ahead. If you are hearing me well, I would like you to start the topic. Dr. S. N. Patel from Polo Hospital and Dr. Amit Munjal from IECR. Both are cardiologists in clinical and interventional.
Thank you, Gupta, for your good introduction, and really I possibly don't deserve all those things. But however, I've been given the topic of heart failure. Are my slides visible?
Yeah, perfectly all right. Slides are visible, you are visible, and you are very well audible.
As you know, that heart failure is a syndrome of symptoms and signs, and as per the universal definition, there should be structural deformity in the heart, along with the rise in the BNP or natriuretic combinations actually give rise to the diagnosis of heart failure, and I'm going to talk on the update on management of this heart failure. It's of course a global health problem, as Dr. Vivek has said, but the burden of heart failure in India is gradually increasing and increasing because of the fact that the AMIs are surviving more and more, interventions are being done more and more, the longevity of the Indians have increased. So with all these, actually, the burden of heart failure in India is a really alarming situation right now. Very interestingly, the heart failure in India actually occurs 10 years younger as compared to the Western counterparts. And also, it affects the lower socioeconomic group in India because of the more rehospitalizations, because of the economic factor. And similarly, the post-admission mortality is also formidable in India as compared to the Western counterpart. The 1-year mortality as well as the 5-year mortality are very, very high. But what is very important that you should know the concept of heart failure. As you know that it has been recently covered as a continuum, the pivot of which actually revolves around the ejection fraction. And as you also know that the ejection fraction can be classified into many types. Out of these 3 types are very, very important. One is the heart failure with reduced ejection fraction, when the ejection fraction is less than 40%, and preserved ejection fraction when it is more than 50%. And in between, it is the mid-range ejection fraction or mildly reduced ejection fraction, where it is the 40 to 50, 49% is the left ventricular ejection fraction. And there could be interchangeability between all these three because of the either deterioration or recovery, as you have seen in this slide. And there could be also combination of the various manifestations or various cohorts of the patients which can be attributed to reduced ejection fraction, more as in younger age groups, CME, diabetes, etc. On the other hand, the preserved ejection fraction with older age female sex and various associated diseases. And in between is the heart failure with mid-range ejection fraction, which can happen with both the groups of the cohorts of reduced ejection fraction and preserved ejection fraction. And almost 50% cases are attributable to the reduced ejection fraction, and rest 50% to the combination of preserved as well as the mid-range or mildly reduced ejection fraction. And out of this, 1/3 is the mid-range, and 2/3 of 50% is preserved ejection fraction. Now, why we talk about the ejection fraction, especially measured by the echocardiography, there could be other modalities which can give the indication that the continuum could be much more sinister. And this could be ascertained by the MRI or by the myocardial strain assessment, where even with the normal ejection fraction, there could be lower ejection fraction. And as I have already told that the raised in this natriuretic peptide level, along with the structural abnormality in the form of mid-range or reduced or preserved ejection fraction can give rise to the various manifestations and various complications. Now, there could be different risk scoring of heart failure, which is very, very important for knowing the management. And what for heart failure hospitalization or death is a new one which has been published in 2022 and based on various risk factors, ejection fractions, systolic volume, RV systolic pressure, CKD, etc. And as the number of risk factors increase, as in the quad risk score ranging from -3 to 15, it can be more having the effect on the mortality. Same way, the preserved ejection fraction as well as the mid-range ejection fraction, there could be other risk factors which can attribute to the mortality and morbidity of the patient. Now, the event rates and death rates for heart failure also are different, especially with the reduced ejection fraction. It is much more as compared to the preserved ejection fraction and mid-range ejection fraction, and the cumulative rate of events are also more, and the all-cause mortality are also more with the reduced ejection fraction as compared to mid-range ejection fraction and preserved ejection fraction. But the history of recent hospitalizations for heart failure provides a means to identify a high-risk patient population in future trials with heart failure with preserved ejection fraction. Now, the conceptual basis of treatment of heart failure actually started with the concept of definitive ejection fraction and various trials ranging from the heart failure ISDN trial to the DELIVER trial, which has been published in 2022. All these based on various positive trials, and they have attributed various drugs, out of which 4 important drugs are very, very important. One is the beta blocker, second is the ACE, then ARB, ARNI, as well as MRA. Third is the SGLT2 inhibitors, and fourth is the MRA. Apart from this, there are other drugs like ferric carboxymaltose, ivabradine also, which can influence the morbidity and mortality. But out of these 4 are called the foundational therapies for heart failure, like RAS inhibitor, SG2, LT2 inhibitor, beta blockers, MRA antagonist. Now, for heart failure with reduced ejection fraction, all the foundational drugs are having the class 1 recommendation, and as you know that recently all the 4 drugs have been attributed to improve the mortality and morbidity when you start the drugs almost in succession within 4 weeks of starting the drugs, as compared to the conventional therapy where sequential titrating the dose is done. But here, all the drugs like BB, then SGLT2 inhibitors, ARNI, MRA are completed within 4 weeks. Now, the conceptual basis of treatment for heart failure with preserved ejection fraction, definitely all the drugs mentioned were tried, and out of them, all the trials have shown the neutral result. And the SGLT2 inhibitors actually showed the paradigm shift in the management of both the MREF and PEF because of the fact that they cause natriuresis, improve cardiac biogenetics, inhibition of cardiac sodium hydrogen exchange, reduction in interstitial edema, reduction in preload, and improved kidney function. And thereby, the SGLT2 inhibitor actually has shown a very, very important result in terms of the mortality and morbidity reduction. It started with the soloist WHF trial where the sepagliflozin was better than the placebo. Same way with the empagliflozin where both the recommended hospitalization and death rates were reduced. But what was importantly observed with the empagliflozin that when the ejection fraction was more than 60, it did not show much better result as compared to the placebo. And the TDM 2022 regarded all the drugs as a class 2A or 2B indication for heart failure with reserved or mid-range ejection fraction. And as you know that the diabetics are already earmarked as the class 1 indication.
Chawla is a senior physician in Delhi. We'll be talking to you for a few minutes. And can you come on the stage? Or you take a mic?
We'll first add the beta blocker because that has been shown to be very, very effective in the management of the heart failure. There is no doubt about that. And that's why this beta blocker in heart failure with reduced ejection fraction has been attributed as a class 1 recommended drug. Now, if the heart rate is still above 70 per rate, that is the indication. If the heart failure is this heart rate is more than 70, then you can add, not substitute, you can add the evabrad into that so that the heart rate falls or comes to around 70. And along with that,
we generally prescribe the drugs. If the patient have a heart failure with reduced ejection fraction and the patient have a chronic heart failure, then the first drug that gives the moderate benefit to the patient is the ARNI, number 1. Number 2, but for the symptomatic benefit, we have to start the diuretics because the ARNI also have diuretic actions, but not as much as required by the patients. Number 2, beta blocker is the drug that can be started only when the patient is decongested and dry. Otherwise, heart failure may precipitate.
Absolutely, absolutely. I completely agree with you.
One thing which I have coming to my mind, Dr. Das, we always treat such patients ejection fraction 15%, 20%, 25%. We give ICD, we see if there is indication for CRTD, we will do CRTD, otherwise not. A lot of patients they don't agree for LVAD because LVAD as such is a good destination therapy, but at the same time it is a higher risk, not less than 10% in the best of the centers. And so what do you think? Do you think that these patients should continue on optimized medical therapy, but at the same time we lose them many times because finally it's a heart failure and you can't do much except for the best of the treatment with the GLP inhibitors, new drugs coming up. We have to live with it, or we can do something more effective or think, or we should we really push for LVAD in most of the patients with their recurrent heart failure? Because LVAD itself, we tell them 5 to 10% is the overall risk of the surgical treatment, and we have personally lost few patients.
Recurrence of heart failure. The most important factors that play in the patients are the various etiological or precipitating factors. If they are treated well, definitely the chance of recurrence of the heart failure and chance of recurrent hospitalization will reduce. Having said all this, so far the question of the various device therapies is concerned, definitely the CRT and CRTD, they have changed the scenarios, especially after the valid 2 trials and all, they have shown the definite improvement in ejection fraction. Now, some group of cases of CRT and CRTD also fail. In those cases, if they fail, then possibly LVAD is a different good option. But as it is a very, very costly affair in many centers, in your center definitely the patients are getting the benefit, but in many centers the facility is not available, or if it is available also, they are not affordable.
Available on phone, we said we will be talking about devices, but in the meantime, we will request Dr. Amit Munjal, he is in the morning talk, to go and present his talk. He is from SAR, a young interventional cardiologist. Dr. P.K. Pandey and Dr. Shastri, I would like the colleague stay back for some more time and just stay for finishing at 6 p.m. So Dr. Amit Munjal will be speaking about the acute coronary syndrome.
Thank you, Vivek sir, for such a kind introduction.
Yes, sir.
I am Dr. Amit Munjal, practicing as cardiologist at IECR. Today I will be discussing approach to acute chest pain. Chest pain broadly defined by any discomfort in the anterior thorax occurring above the epigastrium and below the mandible. Gastrointestinal causes leads to 42% and ischemic heart disease leads to 31%. Rest is chest wall syndrome, pericarditis, pleuritis, pulmonary embolism, and lung cancer, and aortic aneurysm, aortic stenosis. Common causes of chest pain. Cardiac is myocardial ischemia and myocardial infarction, and aortic dissection. Aortic dissection has sharp pain. Then esophageal causes esophagitis, esophageal spasm. Then pulmonary causes are also there: bronchospasm, pulmonary infarction, pneumonia, tracheitis, pneumothorax, and musculoskeletal causes like osteoarthritis, rib fracture or injury, costochondritis. It's also called Street syndrome. Neurological causes are prolapse intervertebral disc. Any adult male more than 30 years or post-menopausal, a female complaining of retrosternal chest pain should be suspected to have myocardial ischemia until proved otherwise. This is the pain assessment model, which we can like assess the pain by the following characters, like site, where exactly the pain is, onset of pain, like when the pain started, how long is the duration, what is the character of pain, like it's any heaviness in the chest or any pressure sensation over the chest, whether it's radiating or not. Radiating to, like cardiac chest pain generally radiate to left upper limb or sometimes both upper limbs, jaw, back. Any associated symptoms like nausea, vomiting. Gastrointestinal pain generally have nausea and vomiting. What is the duration? How long is the duration? Any relieving factors, segregating factors, like any position, like lying down and sitting up, whether makes the pain worse or relieves the pain. Any severity. So this can be remembered by the mnemonic Socrates, SOCRATES. Like this is the universal pain assessment tool. Like 0 is no pain and 1 to 3 is mild pain. And 4 to 5 is moderate pain, then 5 to 7 is again moderate pain, 7 to 9 is severe pain, and 10 is worst pain. History taking is also very important in this like assessment of chest pain. You can ask about the onset, site of pain, character, duration, radiation, any aggravating or relieving factors, any tenderness. Local tenderness is present in musculoskeletal pain like T syndrome, any associated symptoms like nausea, vomiting, any severity. Characteristic of chest pain site is cardiac ischemic pain is generally central, may radiate to jaw, neck and left arm. Patient complains of chest heaviness, any pressure on the chest. And pulmonary chest pain or respiratory chest pain localizes to the site of pathology. Infection or pneumothorax, or patient with asthma or COPD may complain of central chest pain or tinnitus. But other features is the subsequent history will help it differentiate is this from cardiac ischemia. Musculoskeletal chest pain localizes to the site of pathology or injury, may relate to posterior chest region of the spine. Peptic ulcer disease or gastroesophageal reflux disease generally relate to epigastrium or lower chest. Nature of chest pain. Cardiac ischemic chest pain is pressure-like sensation or heaviness in the chest. And respiratory and musculoskeletal chest pain are sharp and pleuritic. Pericarditis pain is sharp and pleuritic. Nerve root pain is band-like shooting pain around the chest from back to anterior chest. This is generally seen with the herpes zoster. Gastroesophageal reflux disease is sharp and burning sensation. And radiation chest pain, cardiac ischemic pain generally radiates to jaw, neck and arms. Aortic dissection, peptic ulcer disease and pancreatitis pain radiates to back. Now root pain forms a band around chest wall, like band-like pain sensation. Then onset, duration and frequency. When did the chest pain start? Does the chest pain come on suddenly or gradually? It is constant or intermittent? If intermittent, how frequently do you experience chest pain? Precipitating like exertion. Cardiac chest pains are generally precipitated by exertion, relieved by rest. Whether it's precipitated by deep inspiration or not. Respiratory, musculoskeletal chest pain, pericarditis pain are precipitated by deep inspiration. and musculoskeletal pains are precipitated by movement. Gastroesophageal reflux disease pain is precipitated after meals. Whether any relation with position, pericarditis, pancreatitis, gastroesophageal reflux disease, worse by lying down or bending forward. Relieving factors is cardiac chest pain is relieved by rest, or sublingual nitrates relieves chest, ischemic chest pain, esophageal spasm, antacid relieves peptic ulcer disease pain, gastroesophageal reflux, simple analgesics relieves musculoskeletal pain, and bronchodilator relieves asthma or COPD pain. Associated features: cardiac ischemic chest pain have nausea, vomiting, sweating, pallor, breathlessness, maybe manifestation of ischemia. Respiratory tract infection have cough, productive or non-productive sputum, fever, hemoptysis. Pulmonary embolism has non-productive cough, hemoptysis, calf pain, history of immobilization, history of trauma, any swelling in the calf, and lung malignancy have productive cough, hemoptysis. Pericarditis have like cold, flu-like symptoms. Peptic ulcer disease have nausea, vomiting, hemoptysis, and melena sometimes. Gastroesophageal reflux disease, which is called GERD, also has acid taste in mouth, dysphagia. Musculoskeletal has back pain, joint pains, nerve root pain, like it's seen in shingles. Inquire about the history of any chest trauma. Past medical history is also very important, like in cardiovascular chest pain, past medical history of smoking, hypertension, diabetes, family history of MI, previous history of myocardial infarction, thrombotic risk factors like previous history of thromboembolic disease, thrombophilia, malignancy, immobility. Peptic ulcer disease requires ask patient about any previous history of endoscopy. And pneumothorax, recurrence of pneumothorax is common, and up to 15% of recurrences can be seen on chondrolatotide. Medications inquiry about any drug history, patient already any drug for this cardiovascular disease, any compliance to therapy. Then social issues like smoking habits, which is #1 risk factor for cardiovascular risk factor. Alcohol consumption, inquire about the job history, heavy lifting, manual labor may contribute to musculoskeletal pain. Ischemic versus non-ischemic chest pain. Like ischemic chest pains are central and diffuse, whereas non-cardiac chest pain peripheral localized. Ischemic pains radiate to jaw, neck, shoulder. They are tight, breathing, choking in character, precipitated by exertion or emotions, relieved by rest or nitrates, associated with breathlessness. There is no such history in non-cardiac chest pain. Chest pain due to ischemic heart disease may manifest as angina pectoris, relieved by rest, not associated with vomiting. Myocardial infarction not relieved by rest, associated with vomiting. You can see here the normal artery and the blocked artery. A plaque is seen there. Characteristic of cardiac pain. The pain of MI typically takes several minutes or even longer to develop. Similarly, angina builds up gradually in proportion to intensity of exertion. The pain of aortic dissection, massive pulmonary embolism or pneumothorax is usually very sudden and interstitial onset. Cardiac pain is typically located in the center of the chest because of denervation of the nerve supply to the heart and medium. Radiation, ischemic cardiac pain may radiate to neck, jaw, and upper or even lower arms. Occasionally, cardiac pain may be precipitated only at sites of radiation or in the back. They typically use characters for cardiac chest pain like open hand or clenched fist when describing ischemic pain. It is called Levine sign also. You can see the patient showing the Levine sign, like heaviness in the chest or pressure over the chest. Anginal pain occurs during exertion and promptly relieved by less. The pain may also be precipitated by emotion but tends to occur more relieved during exertion, after a large meal, or in a cold weather. These are some risk factors for development of ischemic heart disease, like male, gender, increasing age, hypercholesterolemia, hypertension, cigarette smoking, diabetes mellitus, obesity, sedentary lifestyle, and genetic factors. These are some of the life-threatening causes of pain, like acute MI or acute coronary syndrome, pulmonary embolism, acute aortic dissection, and tension pneumothorax. But there are so many causes of chest pain, from benign to life-threatening. But we have to be more careful about life-threatening chest pain. We can assess patients by any like character of pain, any past medical history. And examination, vital signs, ECG, X-ray. The take-home message is that we should not ignore the life-threatening chest pain. We must assess this properly. Thank you, sir.
Hello.
In that situation, if the patient have a typical chest pain, you have to do the ECG. If first ECG is normal, then wait for 10 minutes, repeat the ECG, because first ECG or second ECG, there is 50% chance that you miss the diagnosis of chest pain as a ACS. So you have to repeat the ECG. Second, if the echo is available, you have to do the echo so that you can diagnose the regional wall motion abnormality. So in any suspicious cases of cardiac chest pain, you have to do the imaging if available, and also the cardiac biomarker, which have an important role while the diagnosis of cardiac chest pain. Now we are moving for the next session, and next session is for coronary intervention, and the first lecture is by Dr. Vivek Gupta. He is the senior consultant at Apollo Hospital, New Delhi, in the cardiology department. He has an immense role.
Anticoagulation. My personal practice is why I'm talking about this, although the number of head counts are too low, but it's being recorded on Facebook Live and public is also watching, and we will keep working to watch. So what I want to tell you that instant stenosis, although low, is still there, but it's too low. I tell all my patients when they have 2-3 stents that if you continue to have medicines regularly and if you continue to get a good consultation, your patients and you will be safe. So instant stenosis is almost negligible as of now in my patients. If you do a good job, if you put a good deployment of the stent. Negligible means less than 1 or less than 2%, 3%, which is very less. And at the same time, subacute thrombosis in my personal patient in Apollo Hospital are extremely low. So there's a catch actually. Subacute thrombosis is a big problem. Still it is 0.2%. It's being recorded up there. Dr. Patel, if you see the literature, the subacute thrombosis rate is still 0.2 to 0.5%, which is, and that can lead to sudden death. Can be cardiac arrest. But if you put a good stenting, deployment good atmospheric pressure, and continue anticoagulation, which is not in the trials given by ICC or ESC. They say, okay, if you get a good deployment, just antiplatelets, no repair. When I was working on the LLP repair, no repair was used, except for the time of procedure. But I personally felt that if I continue to give, at least for 3 days, low membrane heparin in my patients, the initial thrust of the body to form a thrombus at the time of stent is gone because you are giving anticoagulation. Now with the radial stenting, vagal artery approach, and also with the good body compression, I think this is an achievable task. Although the trials, the data, Americans, Europeans do not use any anticoagulation post-stenting unless there is a reason for it, there is some clot, something like that. Routine cases, but I am personally using all my routine cases. And fortunately, I can tell you, I can vouch that the subacute thrombosis in my personal and in Apollo also is extremely low. Extremely low is almost negligible. That is one fear in the mind of interventional cardiologist, that patient will have acute closure of the stent is gone. Instant stenosis can be managed. In case we have it after 6 months, we can put another stent. So I would say that considering that if you compare the data with bypass surgery, angioplasty versus bypass surgery, I personally feel if you can avoid bypass surgery by putting 3, 4, 5 stents, maybe in staged manner, 2 stents today, the most important artery and any you do it. Dr. Amit Munjar will agree. And you can stage it after 2 weeks, another group of stents. Then even with 3 stents, 4 stents, patient will continue to live long. I would like at the same time, I would like to give you the example of Raju Srivastava. Now he's no more a personal friend. But I want to share, a lot of people thought why he died. Why he died, first of all, no very few people knew that he had 7 stents already. 7 counted stents, not at the same time, 3-4 times. Once I diagnosed him in Apollo also. It was a CT coronary angiography which we did. All the stents were deployed in Bombay. Because he was from Bombay, so he was getting his treatment in Bombay, so all his stents were deployed by them. And he was taking my treatment. My prescription was following. He was fully active. He was doing extreme high quality gym. I would say quality and high quantity also. Every day. He was well maintained in body. He was in jumping, dancing, no arthritis. Sometimes not to have osteoarthritis is also not a boon. It's not a blessing. If you have osteoarthritis, you will not jump and walk as Raju was doing. He cannot go to the gym. Severe osteoarthritis will not go to the gym. So that can be safe for the cardiac patients. So he was taking lunch, dinner. He came to my house on exactly on 7th August. And he practically died in 10 hours. Practically means he was on ventilator, he had cardiac arrest, although he died actually after 40 days of ventilation. But practically died because he was hardly having any brainstem infection, but yes, he was still alive. So he had a severe cardiac arrest on 10th August around 11 a.m. to 12 noon in the gym. And when he was singing a song, I was showing the video in the evening, when he was singing a song, doing good comedy like my national Sarta Bihar, he was absolutely fine. So what happened in those 2 days? Nothing. So I spoke to him because he was sitting beside me for at least 2-3 hours. I told him everything is fine. I just asked him in car में, सब ठीक है ना? हाँ सब ठीक है, बात करेंगे. So being a celebrity sometimes is a curse. Why is it a curse? Because he thought in front of everybody, if I talk about myself, it will not be good idea. बात कर लेते हैं. Later on, I came to know from his wife that actually he had just prayed about it 2 weeks back. And he wanted to consult me, but he had no time, or he could not find time. He took it lightly. So if he had consulted me at that time in my office, की boss Vivek कहता था मेरे जी मेरे दर्द हुआ था क्या करूँ, तो कम से कम पहला काम ये करता है कि उनको कहता है जिम मत करिए, एटलीस्ट ये तो रोक ही देता था. But he avoided बात करेंगे. 3.5 घंटे की बदल गई, 8 p.m. to 11:30 p.m. in my house, 7th August, 10th August died respectively died. अब वो इसमें दवाइयाँ खाने थे, but sometimes these stents get accumulated stent incidents later on. Then I saw all his reports once he had a cardiac arrest. मैंने देखा कि यूनिवर्सिटी एंजियो कराया था, which was about 1 year back. It had a ostial circumflex instant stenosis. That plaque ruptured and here you can find. What I mean to say that 7 stents he lived for more than 12-15 years with those stents. But if he had been a little more cautious, he would have continued to live again. I mean, we have missed him, that is another story. So it's a learning is that stents do very well. But you have to be cautious in going to your physician or cardiologist every 3 months to 6 months and get your routine checkup. Don't ignore any minor symptoms. Don't ignore even minor symptoms. They can be a warning signal for you. So after all these things we are able to do, but still I would not say bypass surgery. Still I say many times we cannot do it. Many times the condition is a left main triple vessel disease with fibrotic lesions, with calcific lesions, with patient not affording full stent, long-term good effect, normal airway functions or poor airway functions. In all cases, bypass surgery will continue to stay, and angioplasty will continue to grow. And you may have some magic stents sometime later in the future. You don't know after 100 years, maybe just put your hand on KK part and think, okay, आइए आप मैं नसें साफ कर देता हूँ, हाथ लगाया, clear हो गया, CT एंजियो कराया नहीं. So something will come. We don't know after 100 years we don't live, so we don't know what's going to happen, and the things will improve. Thank you very much.
I was telling you, I think you did not listen. Bioabsorbable stent became a very important tool, and everybody wanted to do this. They said, I don't want to live with stent. It will be gone, I will be happy. And secondly, you can put a bypass graft. If you have stent, there is no stent, you can also put a bypass graft. The Abbott company, they sold it and we used it continuously for at least 5 years. But there was some data which showed that something is happening, and later on, even these absorbers and the polymer was causing high incidence of acute closure. And that is why it was taken off from the market by the company itself, considering ethical reasons. So now there's one company which has recently introduced, I want to use this stent. But we have a cardiologist stent by one company in our lab, but we will not use it. So
giving me the opportunity for presentation of the case here. So my case is complex dual CTU with decay crossing triforgetting left main, the real chief. And the history of this patient is that he is 42-year-long male, known case of diabetic and hypertensive, with a history of angina on exertion for 2 years. Stress thallium was done 2 months back, showing the significant stress-induced reversible ischemia in the LV myocardium. Now patient presented with the unstable angina, ECG showing STD changes in the anterior chest lid, and the echo reveal hypokinetic LAD-LC extraordinary with an ejection fraction of 30%. BP of this patient is 106 by 68, pulse rate is 86 per minute, and serum creatinine is borderline 1.3 milligram per dl. So because the patient was presented with the unstable angina, so angiography was planned, and the angiography shows the osteoproximal LAD CTO and the critical lesion in the circ, followed by the CTO segment in the mid-circ. So ejection fraction of 30% with double CTO with triforgetting left main is really a challenge for doing the PCI in this kind of patient. And the second challenge in this patient is that the syntax score is 32. So this patient is ideal candidate for CABG, but he refused to go for the same. So in dual LAD LCX CTO with left dominant system made procedure challenging, especially in patient of low ejection fraction. So bifurcation strategy with a decay cross considered as an appropriate approach, and the patient was taken for the bifurcation strategy. As this patient was the high risk patient, so intra-aortic balloon pump was prepared but not inserted because of the cost issue. So 2 access was taken, one from the left femoral artery 6 French and the right femoral artery 7 French. The EBU guiding was taken, and the initial wire was filter FC so that we can fix the microcatheter in the proximal cap, and with the help of filter FC, the microcatheter was fixed in the proximal cap of the LAD, and then we changed the filter FC wire because the lesion was CTO, so we exchanged the fighter wire with the more deep load. But after a certain period of time, the fighter wire was not going forward, so it was again exchanged with the ultimate Prof 3 wire that had a tip load of around 3 grams. But after going a certain distance, this ultimate cross was also failed to cross the proximal CTO cap. So another wire was taken, that is Gaia 3. So with the Gaia 3, I was able to penetrate the cap of the CTO segment in the LAD and ultimately enter into the true lumen. After entering into the true lumen, because the lesion was very tight, so it was dilated with the 1 into 5 millimeter balloon, and then the flow in the LAD was achieved. Once the flow in the LAD was achieved, I took another filter XT wire for negotiation into the circulatory with the fine cross as a microcatheter. So with the help of fine cross as a microcatheter, we advances the wire, the filter XT in the circ, but it was unable to go after a certain distance. So it was exchanged with the Gaia wire, but Gaia 1 wire goes into the subintimal plane, so false lumen was created. Now, the Gaia 1 wire was exchanged with the Gaia 3 wire because the Gaia 3 wire had a more tip load. So ultimately with the Gaia 3 wire, I was entered into the true lumen, and the circ was now open with the balloon, flow achieved in both LAD and circulatory. So now after pre-dilatation, proximal to mid-circ was stented with the 3 into 24 millimeter synergy stent, and for the proximal circ, I use another stent that have a size of 3.5 into 16 millimeter. So from ostial to proximal, we used the 3.5 into 16 millimeter stent, and after wiring with this circ, I actually crushed this circ stent. So proximal part of circ stent was crushed with the 3.5 into 10 millimeter balloon with the 12 atm pressure, followed by recrossing with the wire, and then kissing was done with the 3.5 into 10 millimeter balloon in both the circ as well as the ramus intermedius, and the kissing was done at 12 to 14 atmosphere. Now, once the circ was stented, now a stent taken for the LED, and 3.5 into 28 millimeter synergy stent was taken into the LED, inflated, and it was dilated by the 3.5 into 10 millimeter of NC balloon till 14-16 atm, and then first port was done with the 4.5 into 8 millimeter of the balloon in the left main. Again, the wire was crossed to the circ and LED. Kissing was done. Second kissing with 3.5 into 10 millimeter of balloon and up to the 14 atm. And the final port was done with the 5 into 6 millimeter of balloon in the left main. And this resulted in the final TB3 flow in this patient with the good end result. So the take-home message is ostial LED CTO along with the LCX CTO in left dominant system in the background of ACS and severe LV dysfunction and nephropathy is the real cheap. Without imaging modality and ventricular assist device like Impella, it further become more challenging. Clarity of step and careful pre-procedural planning with the less contrast use is the key determinant of success. Bifurcation standing with the DK cross is the preferred strategy considering the long-term outcome. But meticulous CTO analysis and operator skill can lead to the successful outcome in such kind of cheap cases. Thank you for the patience listening.
Accident relation, sir. It is going to ask you first you started LCX and ramus intermediate, then left main quality you started.
I actually entered into the ramus, only wiring was done, and because of this was the DK crush was planned in the strategy, so I actually crushed the proximal part of the LCX stent with the balloon, 3.5 into 10 millimeter, and then again recross the LCX stent, and again we take the stent into the LED, dilate the stent, and finally we do the port. Again we take this because once we dilate the left main stent, then recrossing is essential for the DK crush. So recross the stent and we do the kissing followed by the final.
Wearing 9 instance, and he's not going under the knife. He says, I don't want to do bypass surgery, and that's sometimes a huge fear because, and then he's still continuing on medical treatment. I said, okay, we'll do 3 times angioplasty. He did not have that much money. He wanted at least 7 stents to be put in the same time. Nobody will do it. And I in fact took it. It was taken off from the lab in Lilavati Hospital. So such patients are there. But you have done a good job. You should be congratulated. One of the best, I think, result anybody can achieve. Dr. Adi Yadav missed his great presentation from Dr. S. N. Pathak, our colleague and friend from Apollo Hospital, Delhi. So thank you very much and congratulations for doing such wonderful case. And also to Dr. Munjar.
Thank you, sir. Thank you, sir.
Heart failure means ejection fraction is low. That is, heart pumping functions have come down. Pumping functions. So this is a very important topic, and this causes many patients sudden cardiac arrest, and also the patient requires recurrent hospitalization for the treatment of heart failure, breathlessness, acute onset, or patient not able to walk, chronic fatigue. All these things are symptoms of heart failure, which is mostly one of the consequences or sequelae of acute MI. Mostly, but sometimes myocarditis and dilated cardiomyopathy. that means the muscle weakening on its own can also lead to heart failure. So Dr. R.D. Yadav is a very important young, or can I call you young? He should have come today. He's from Delhi only, but he's traveling to Lucknow. So he said he will give virtually, and I'm obliged to him that he could find time. We will talk about the device treatment of heart failure. Device means when you do something like pacemaker, or not actually pacemaker, something which is deployed just below the clavicle and implanted, and that increases the lifespan and sometimes reverses the heart failure, and sometimes it can increase ejection fraction. So we will talk about this development in this technology. The first CITD, again, Patel, you were not there in Apollo. First CITD was done in one of my patients, and that was when Dr. Claire came to support us in Apollo. That was 2004 or 5 CITD. At that time there was CRT, not D. It was CRT which we did. And now a lot of people are doing it, but still the physician should know the impact, and that is why, because you see a lot of time the patient does not know that what are the treatment directives, because the physician do not know. I'm a physician sitting in primary health center or community health center or in the remote areas, they are not aware of such treatment. That's why these education programs are important, because if you update the knowledge and skills of the physicians, that will finally help the patients sitting outside and not knowing that this important landmark development in cardiology. Dr. R.D. Yadav, please finish your piece. So I was speaking.
As you know, pathophysiological progression of cardiovascular disease, coronary artery disease, is responsible for 60% of the congestive heart failure. Other causes, hypertension, cardiomyopathy, valvular heart disease, are remaining 40% responsible for heart failure. And they who are class 3 heart failure, majority of them, 2/3, they will die of sudden cardiac death. And another 1/3 will die of pump failure or other causes like pneumonia or infection, some other cause. But as the as the New York Heart Association class deteriorates to class 4, they 33% die of sudden cardiac death, and another 56%, means around 2/3, they die of pump failure. So mainly sudden cardiac death occurs in your class 2 and class 3 patients. If you see the medical therapy, neurohormonal interventions in the heart failure, they also reduce the sudden cardiac death. Like in TRACE trial, Pandora pill, 10 DOLA pill were used, where sudden cardiac death reduction was 24%. In HOPE trial, Revascularization was used, 38% reduction. RELS trial, 29% reduction. CBS2, 44% reduction, which is beta blocker. MERIT-HF trial, where metoprolol succinate was used, 41% reduction. And Copernicus trial, carvedilol, although this Copernicus trial is class 3 and class 4 patient, sicker patient, 35% benefit in mortality. SOLVE T treatment and SOLVE prevention, they showed only 10 to 7% sudden cardiac death reduction. So,
Shetty agreed to speak on the healthcare, although I could not contact him in last 1 hour. If he comes in time, we will have his talk also. They will Shetty talking about the future of healthcare, 10 minutes. Then we are recording lecture by Dr. Jack Vivek from US. And then of course Dr. Girish Taki was physically present here. And then Dr. Rachna Balwani will also speak from US regarding the cardiovascular disease in adults. So we start immediately, and I will start with this topic of TAVI, transcatheter aortic valve implantation. Can we have a good picture? Although the first case was done 20 years back. 20 years, huge time. 2002, Alain Riviere, France, Rouen, Hospital Charles-de-Gaulle, the place where I did my early training of angioplasty, 1996-98. So TAVI is a very important life-saving modality for aortic stenosis, degenerative, and also for aortic regurgitation, also for younger population, and also for less risk cases. All this started all of. It's a very important talk. So I'll talk something which even the people can understand. Public, non-medical people can also understand. Being recorded, it will go on people, general public also. So the topic is transcatheter aortic valve implantation, bedside to bedside. Bedside is when you start animal experimentation. Bedside is when you start doing clinical usage of that topic. So bedside to bedside. First of all, I would like to tell you that the person who did the first aortic valve is Alain Riviere. And he is one of those not yet received the Nobel
prize, but likely to receive Nobel, has been already been nominated. Dr. Krivier at my residence, few memorable photographs before I go on to the topic. At my residence in Santa Vihar. Then my son Chinmay, Dr. Krivier on bicycle. He's showing how to, this is 96, 97. Then this was one of the ESC meeting, and this is, these are the cath lab where I used to work with Alain Krivier in France at the age of almost 30. At that time I worked with him, and this is his young Dr. Alain Krivier. Dr. Krivier in one of the restaurants, myself, my wife, and Chinmay. It was the first actually TAVI case, Dr. Abid, you might know, first Indian patient. This is the first Indian patient operated in Rwanda. Our case, referred by Dr. Chikemani to me. And this is Dr. Krivier who did the procedure in 2013. At that time, 11. We started doing procedures in India in 2012. Because at that time, neither Edward or Medtronic valve was available. This was the first Indian case done in France by Alain Krivier and myself when I was in the cath lab. This is the cath lab of Hospital Charles Nicolle. This man is a big industrialist, and he lived for another 7 years post-valve, 40 minutes procedure, 40 minutes by watch. In that time, 40 minutes, no anesthesia. Patient was conscious all through. And within 40 minutes, Dr. Krivier finished his procedure of Edward valve in front of my eyes, shifted to the board, and then I'll show the few slides of these cases. So these are the important photographs, and this is the first case. So 20 years have been passed. So first case was done in 2002, April 16. I was not there because I came back to India at the time I was working in Bodo. I was there only 96 to 98 when he was thinking about it. He was doing animal experimentation. So I was part of those experimentation, and I was part of those thought process and the struggle which he had to go to do the first case. So this was actually the first case, April 16, 2002. First film means first in man. First in man case done, and we had a 20-year celebration this year in Rouen in May 2022. 20 years passed, and I was there. I was invited, and there were a lot of doctors. Dr. Martin Leon, Greg Stone, Fajade, all big cardiologists of the interventional community were there to celebrate this event of 20 years in France. Dr. P.C. Rath from Hyderabad was there with me. Oh, incidentally, I was wearing the same coat which I am wearing today. A different tie, okay. So I go on. This is one of chapel. Chapel means a big church where for example, in the big church they have a huge banquet hall and they allow such ceremonies to happen. And this was done there. This is an old photograph. Dr. Krivier and his wife, 97th perhaps, Chinmay, my son, myself, my wife. I have a wonderful stay with him. Dr. Krivier is not only a very big operator, but he's a very, very nice human being. So this was the photograph which he shared during 20 years TAVI celebration. He's written in French. One of the photographs, when I was working in 97, he showed few photographs of few fellows who worked with him. So this, I took the photograph from him, from his slideshow, which was going on during that evening celebration. Amit, you were not there. You would have come if you would have enjoyed the celebration, April, just before the EuroPCR, in May 2002. So this was the photograph which I took. I was so very happy to see myself in that program with Alain Krivier, which he had selected for the slideshow which was going on during the evening celebration of 20 years of TAVI. So this is how he was there, and physically present there, myself, the same coat, and my Chatan and Dr. Krivier on May 16, I think it was there, 2022 in Rouen in France, one of the chapels. So let me introduce him also. He's a young guy. He is a treating doctor of Dr. Krivier. Dr. Krivier had to undergo himself a stent implantation recently. And so I met him. He said he was an emergency call. It's very interesting because I will talk something different because people speaking science, but I would like to tell my experiences. So he said that he was on call in a small city of France, in the south of France, and Dr. Krivier was on vacation. He had chest pain. And he had chest pain and he granted an emergency with him. So he said, he was telling his thought process, young cardiologist, treating a very senior cardiologist of France. He said, I came to know, I got a call from a phone that there's some Dr. Krivier in emergency. Tragic. He said, I thought it should not be Prof. Alain Krivier because he had not wanted to treat him.
a small young cardiologist treating a very big man. So he said, no, I went to try and found that it was actually arrhythmia. So I was shocked and I was very nervous to treat him with emergency angiography, angioplasty instantly. So he was telling his story, so I took his story and so he is a treating cardiologist to Dr. Revascularization. So we all doctors should be aware of their own coronaries. And Dr. Revascularization was so, I would say, relaxed. When I told him, when did you have the blood pressure check? Oh, 5 minutes back. I'm all right, I'm fine. So and he was traveling like anything. And personal thought process that if BAV does not work, let me do something which can be non-surgically. It is always told that don't undertake a project unless it is manifestly important, nearly impossible. This is Edwin Land. He followed this. Don't undertake the project unless it is manifestly important. It should be very important, relevant, and almost impossible. This was something it was almost impossible. So he took this project, and this without this is season 2. The film I told you, 2002, he did the first in-man implantation. In 1980, surgical aortic valve replacement was declined in all patients older than 70 years. 50% was symptomatic. So that was the reason why he took this effect. So how he developed it? Coming on to the hypothesis, developing TAVI was an unrealistic project. Implanting a valve prosthesis. What is the physiology? You are implanting a valve prosthesis within a calcified diseased aortic valve on the beating heart, using percutaneous catheter-based technique without opening the chest. And the goal is to improve the results of BAV, which is balloon aortic valvoplasty, no restenosis. It's highly challenging. Why? Because valvular calcification surrounding structures are coronary arteries. Near the valve is a coronary arteries origin, mitral valve, IV septum. And major clinical issues were coronary occlusion. You can occlude the coronary, patient will die on the table. Mitral valve injury, permanent AV block, stroke, aortic leak, prosthesis migration. Prosthesis will not stay because you're not stitching. And long-lasting results. So how he developed this? A balloon expandable stent with high radial force might keep the valve open. This was his thought process. A balloon expandable stent with high radial force will keep the valve open. And a valvular structure would have to be attached within the stent. A stent-like structure inside the valve where you have attached valve-like structure. This was the hypothesis, a challenging combination of balloon expandable frame in 24 hours. This was a serious patient, challenging decision of transseptal TAVI as a life-saving procedure. All current contraindication of TAVI was there. And this was done, and this was April 16, they did it. And finally, this is 30 minutes post-implantation, 8 days post-implantation, and feasibility of TAVI was established, no THC embolization, no coronary occlusion, no MR, no AV heart block. That means they at least confirmed that this is feasible. And this was done, and then it works. They said, valve positioning, and so you can see the eyes of the people who were Ellen Elshanov, the second in command at that time with Alan Revere, and Christoph Trom. So these people did it and it's published in circulation. And then after that, there have been so many challenging, so many devices. 2002, 2005, historically, first stage was 2002, then till 2005, there was heroic period. I revived recast trials, and then compassionate use only. So this heroic period, a lot of patients, 83-year-old patient, 1 year post-hour, he was shown in PCT meeting in USA, the 83-year-old, 6.5 years post-hour, and patient 3, patient 10. So these are the heroic patients from 2002 to 2022. Transseptal takes its flight to the world. Then, after the French people, then of course New York, Martin Lyon, then Patrick Serras from Rotterdam, Milano, Colombo. From 2005, 100 TAVI were performed in year 2005. So this was the beginning, and other doctors took interest. It was earlier was Crippier Edward valve, because Edward was for making company. Yeah, I forgot to tell you. Edward company which had refused, then bought PVT. They bought PVT and then they became the owner of this valve. Crippier Edward name was changed to Edward Sapien, and now Edward Sapien. So these are the different technical logical designs. Then the surgeons entered the room, and the surgeon said we'll do transapical, and this was being used in limited cases as of now. And so reason for success is there because of this. So I'm not going to detail, I have to finish my talk soon so that we can go ahead with the film. So it became, after partner 1, 2 and 3 trials, it has been used vividly all over the world, especially in USA. And now in India we are doing many cases. More than 1 million, 1.5 million patients have been treated worldwide in more than 70 countries. 15 lakh. So, ज़्यादा पिक करता तो 18 लाख हो गया वो data are not, this is already last year data.
who would believe that this new paradigm, TAVI, is conceived for patients who are not candidates? You see, very important slide, this is very important, just listen to this. In 2002, TAVI should be done for patients who are not candidates for surgical aortic valve replacement. 2002, TAVI is conceived for patients who are not candidates for surgical aortic valve replacement. Now what is it? 2002, surgical aortic valve is indicated in patients who are not candidates for TAVI. It's a paradigm shift in the indications of transcatheter aortic valve implantation. It's such a huge leap and paradigm shift in the indication of this. I would like to show you the first case report before I finish off. This was 83-year-old in 2011, I told you. We took this patient to out of India. Severe calcific valve area 0.7, 83-year-old, male peak in 85, mean in 65. Ejection fraction maintained, hypokinesis in lateral wall, post-bypass patient, long cavities, mellitus. Graft vacancy status was there, but one graft was already occluded. Poor lung function and nephropathy. These were all contraindications for 83-year-old VIP patient. Dr. Mani said, I will not operate this patient because he has a high risk of dying post-operatively or during the treatment. Because of very poor lung function, he will not come out the ventilator. So, surgical consultation led to conclusion of high risk and we decided to do TAVI. We did a lot of preparations, MRI in Apollo Hospital, including MRI of the heart. Because he had nephropathy, we did not do contrast CT, which confirmed the aortic annular size. CT was not performed. Patient was treated successfully for TAVI in Rouen, France, on November 11, I think. We'll show the angio clips. A few clips before we finish this lecture.
And they're evaluated less than 1, they're symptomatic stage 1, and they should be evaluated and recommended for valve replacement. And if they're not symptomatic, then they should undergo exercise stress test and then should be recommended for the stress test for the TAVR. And if they're a paradoxical low flow, low gradient aortic stenosis or a true low flow, low gradient aortic stenosis, if they have either increasing gradients by dobutamine or high calcium score on the CT scan, still they could further be evaluated by the team, our team approach and undergo SAVR or TAVR. And so this is how we do in asymptomatic patients, following up with the echocardiogram every 6 to 12 months is recommended. So all patients with severe valvular heart disease should be considered for valve interventions. They need to be evaluated by multidisciplinary team. We do that every Wednesday, about 30 of us get together, heart failure, interventional cardiologists, cardiac surgeons, and general cardiologists will all meet and decide what is the best for the patients. Though the recommendations that you mentioned are still SAVR is recommended in younger people. Quickly, they are above 65. Most patients are now being looked at whether they're candidates for TAVR or not. But I think rather than thinking that this is a new kid on the block and everyone should get a TAVR, we should understand from the patient's viewpoint what is the lifetime management. Should you have SAVR or TAVR? And if you have SAVR, which bioprosthetic valve do you get? We need to think about TAVR and SAVR in the future. And do you get a root enlargement? And what do we do for younger patients? Less than 65, should we do TAVR? Because, or should we put a mechanical valve as compared to a bioprosthetic valve? And if you do a mechanical valve, obviously you can't do a TAVR in the future. So that's what we need to think about that.
Against them. If the doctor is practicing in Delhi, then of course ultimately whether the complaint is being filed at PMO level or at state health minister, or it would come to the limited for cardiologist. And we receive around 35 to 40 complaints per month. That means 1 to 2 complaints per day we are receiving against the doctors. So I will just talking on that these litigation and how why the litigation is against the doctor and how we can reduce the litigation. Of course, we cannot prevent the litigation against the doctor, but we can reduce the litigation against the doctor. So why is the litigation against the doctor? So in my own terminology, I have a ABCDE. A stands for adverse outcome for an event. B stands for behavior. C stands for communication, and C also stands for comments for other colleagues. D stands for doctor-patient relationship, and D also stands for decision-making non-neural. E stands for expectation of the patient. F stands for financial part. I'll just come from below. A is the adverse outcome or an event. Whenever in that scenario, whenever there is an adverse outcome or an event or likelihood of adverse outcome event, be prepared that litigation will be filed against the doctor or the nursing home or the hospital. B is the behavior. Behavior is very, very important. If the patient himself or his relative are not satisfied with the behavior of concerned doctor, not only the doctor, behavior of all the persons who are involved in the treatment of that particular patient, be the doctor, be the nurse, be the nursing tolly, be the nursing orderly, or dietitian, physiotherapist, etc. If they are not satisfied with the behavior of that particular person who is involved in the treatment of their care, they are likely that they will file a complaint. And see that communication is very, very important, because in our times the communication was not part of the curriculum. We were not told about that, how to disclose the death or to the bad news to the patient or to the relatives. And now, after say meeting the State Medical Council of India at various levels and to the health ministry, now that has been part of the curriculum, and communication is very, very important. And comments of other colleagues is important from the point of view that we at the Medical Council, we found that it is unfortunate that in at least 45 to 50% of the complaint, there is a doctor behind the complaint who is pursuing the complaint, to file the complaint, who is providing literature, etc. to the complainant, and pursuing him not to withdraw the complaint. That is the very unfortunate part. And D is the doctor-patient relationship. In earlier times, doctor-patient relationship was supposed to be a pious relationship based on the faith and trust. Now, after the imposition of the Consumer Protection Act, mainly in 1986, now they thought that doctor is being equated with that service provider, and patient is being just himself to be a consumer. So after that 1986 Consumer Protection Act, now there is an influx of complaints brought against the doctors for that matter. And D also stands for decision making. Nowadays, the patients are available. They are coming to that through the Google, or after going through the talking or discussion with the patient or relatives of friends who might be a doctor. They want themselves to be involved in the decision making. If they are not involving the patient or the relatives in that decision making, then of course likelihood that if the results are not satisfactory to the tune of the patient, likelihood that they will file a complaint. So decision making involvement is very, very important nowadays. E is the expectations or perception of the patient. Expectation, that means the results of expectation from the patient point of view. Suppose the patient is the first stroke, is admitted under a neurologist and a qualified neurologist. So once they are admitted in a qualified person at a good center, they have a apprehension that once they are admitted, automatically they will be okay. There is no side effect, no complication. So from the neurologist point of view, patient might be recovering okay, patient might be recovering smoothly, but from the patient or the relative point of view, they thought that when they are admitted into the neurologist, after 1 week or so, they will just go to at their normal level, which of course they are running, barking, etc., which of course it is not possible. F stands for financial. Financial means it generally applies to the private sector. So if they are paying to the doctor or to the nursing home or to the hospital and they are not getting the desired result, then they are likely that they will file a complaint against the doctor. So F stands for financial, mostly in the private sector. So in current scenario, what are the options available to the patient or to the relatives about that, how they can go against the doctors? So there are various options for the patient or the relative. They can go to the consumer court for compensation. They can also go to the civil court for the compensation. They can go to the criminal court once they thought that doctor has done enough negligence or they have enough evidence to prove that negligence is so great that they want doctors should be behind the bar. Sometimes they think that they will go and approach that police station or the criminal court to file a file against the doctor. So, and they can go directly to the High Court under Article 226 or under Article 32, they can go directly to the Supreme Court, the police or the lower courts are not. And they can also go to the National Human Rights Commission directly, because we are receiving a number of complaints from the National Human Rights Commission also directly. They can go to the State Medical Council or National Medical Commission, or if their patients are feel that there is some violation of state acts or central acts like the Biomedical Waste Act, Nursing Home Act, or Transplantation Act, or various acts applicable, PCPNDT Act or MTP Act. If there is any violation, they can go file with the relevant authorities for that. And unfortunate part of these are the 7 to 8 options that criminal court, consumer court, civil High Court, Supreme Court, State Medical Council, National Medical Council, they are approaching all the fora simultaneously. That means once a complaint is filed, all the fora, that means the board doctor has to reply to that, all the fora at the room. At Delhi Medical Council, we have discussed and asked that representation to the health ministry also, that once let the patient or the relative decide whether they want compensation, they go to the consumer court. If they want that the doctor should be there, they can go to the consumer court. But they should not approach all the fora simultaneously. But of course, because of populistic or any other method, they are free to approach any fora, and most probably they are approaching all the fora simultaneously. That means if once a complaint is being filed, that means one negligence doctor has to reply to a peer or to a different fora simultaneously. Then how can we reduce that litigation? Of course, I have told you that we cannot prevent the litigation at the current scenario. But of course, we can reduce the litigation against us for professional misconduct and negligence. Here also A, B, C, D, E. A stands for availability, B stands for behavior, C stands for communication, and D stands for documentation, and E stands for empathy. Availability, A stands for availability. That means when the patient or the relative reaches that critical care at the nursing home or the hospital or the clinic, the doctor availability of all the 4 M's, that means manpower, machine, method, material, all the M's should be there. If the patient reaches at casualty at a government hospital or a private hospital, if the doctor is not there, likelihood that the treatment will not be initiated at the right time, there will be delay in the treatment, likelihood if there is a complication for an adult hospital, likelihood there will be assault or filing of litigation. Then, if the doctor is there, if the nurse is not there, that means the doctor has prescribed treatment, but there is no nurse to administer that treatment or initiate that treatment, likelihood there will be delay. If the doctor is there, the nurse is there, but nursing orderly is not there. Say that doctor has advised some test, ECG or X-ray or CT scan or any investigation, but the nursing orderly is not there. That means that patient will not be transferred to that particular CT scan or X-ray machine or whatever if there will be delay. Another scenario, if the doctor is there, nursing orderly is there, and nursing trolley is not there, there also will be a problem. So availability of all the M's should be there. B stands for behavior. Behavior is very important. As I have already told you that behavior of doctor, nurse, nursing orderly, sweeper, whosoever is not the treatment of a particular patient at a particular time, behavior of all the patients. In one of the case of filed against the pediatrician, senior pediatrician, because when he came for the round newborn baby for jaundice, the grandmother of the child told that their child had jaundice, and doctor smilingly told that नहीं ऐसा कुछ नहीं ठीक हो जाएगा. The complaint was filed that the newborn was serious, there was jaundice, and doctor smilingly told that कुछ नहीं होगा, and then jaundice increases. So that was of course there was no negligence and then orders were free, but complaint was filed. So behavior is very important. See, communication is very important. Communication, there are 2 aspects. Communicate effectively to prevent error. That is with our team members. Because nowadays the patients are being administered in the multidisciplinary team, with the medicine person will be there, or say neurologist or nephrologist or other specialty team are there. And we have Delhi Medical Council, we have noticed that they are coming at different times. Sometimes they are documenting in the records, sometimes they are not documenting in the records, sometimes they are not communicating with themselves. So either the patient is getting a lower dose, higher dose, or sometimes dose is missed, or sometimes important event is missed. So if you are communicating effectively with our team members, including the nurse, etc., so likelihood that the chances of error will be reduced. Then communicate effectively to prevent dissatisfaction. That is very important. If you are effectively communicating with the patient or the relative, this is the right to the patient or the relatives. If you are effectively communicating with the patient or the relatives, likelihood that they will be less dissatisfaction, or they are less dissatisfied, chances of litigation against the doctor will be reduced. So communication. We have seen two scenarios. In one of the cases, when the case came for hearing at the Medical Council, in the discipline committee we called the complainant as well as the doctor in the discipline committee. When the team of that came, then because the death occurs, then the patient's younger brother was there as a complainant. He touched the toes of the junior doctor and shouting shouting abusively to that senior doctor, seeing that this junior doctor was doing the treatment okay, but he was communicating. But this senior doctor, my brother expired because of negligence on the part of the senior doctor. Because of that, he was not communicating, and so communication is an art. It should be two-way communication, and we should, in the current scenario, we should ask the patient or give the liberty to the patient the letter to ask question, and it should be documented also.
चेकअप होता रहना चाहिए, which should include in a patient जो predisposed है, खास करके जिनके फादर या मदर को हार्ट की प्रॉब्लम है, उनको एक सीटी कोरोनरी एंजियोग्राफी भी करा दें अदर देन दैट। सेकंड इंपॉर्टेंट बात है कुछ दवाइयाँ का सेवन पोस्ट वैक्सीनेशन या पोस्ट कोविड केस में, जिसमें एस्पिरिन तो बहुत सिंपल दवा है, अगर कोई कॉन्ट्राइंडिकेशन नहीं है तो मेरे ख्याल से एस्पिरिन और ये कोलेस्ट्रॉल कम करने की दवा होती है स्टैटिन, एटोरवास्टैटिन और रोजुवास्टैटिन, इनका सेवन मेरे ख्याल से रेगुलर करना चाहिए हाई रिस्क पॉपुलेशन में, क्योंकि दोनों ही क्लॉट बनने के रोकता है और प्लाक रप्चर को रोकता है। तीसरी बात है कि हमारे फादर की बहुत इंपॉर्टेंट रिसर्च है अश्वगंधा, जो कि इम्यूनिटी बूस्टर भी है। उनको 1986 में अभी जो वैलिडेटरी फंक्शन फिर शुरू होगा तो उसमें फादर बोलेंगे भी, जो लखनऊ मेडिकल कॉलेज में रहते हुए 1986 में एक पर्चा छापा था उन्होंने, जिसमें उन्होंने दिखा था 22 में उन्होंने एक्टिविटी की, और ये अश्वगंधा जो विदानिया सोमनीफेरा है, इसका एक्चुअली हर्ब होती है अश्वगंधा विदानिया सोमनीफेरा, ये जो होता है इसकी एंटी ट्यूमर एक्टिविटी और इम्यूनिटी बूस्टर एक्टिविटी पहली बार प्रकाशित की उन्होंने इंटरनेशनल जर्नल में। और आज भी अगर गूगल साइटेशन अश्वगंधा का देखते हैं तो उनका नाम पहली आता है कि 1986 में रिसर्च की। तो इसका सेवन करने में कोई बुराई नहीं है जब तक हम लोग कोविड की महामारी से लड़ रहे हैं। सबसे इंपॉर्टेंट बात मुझे बताना चाहूँगा, चौथी बात, ये सब अगर अभी रिकॉर्ड हो रहा है, जिसके गो टू द प्रेस ऑल्सो, वो ये है कि आपने राजू श्रीवास्तव जी का नाम लिया, हमारे बड़े उत्तर प्रदेश से थे, आपसे कई बार मुलाकात आपकी भी हुई होगी, वो आपको बहुत चाहते भी थे, एक बार आपका जिक्र भी किया उन्होंने, और उत्तर प्रदेश में फिल्म बंधु के वो चेयरमैन भी थे। वो हमारे घर में उन्होंने सर 7 अगस्त को खाना खाया, शायद ये बात आपको मैं उनका वीडियो दिखाऊंगा, और 10 अगस्त को उन्हें दिल का दौरा पड़ा है। अब ये 7 अगस्त को कल 7 अगस्त को उन्होंने गाने गाए, कॉमेडी की, हमारे घर पे एक छोटा सा प्रोग्राम था, हमारे साथ नारायण की कथा हो रही थी, तो उन्होंने कहा, उनका फ़ोन आया कि मैं दिल्ली में हूँ, तो हमने ऐसे कहा कि आप घर में खाना खाने आइए, कोई ऐसा बड़ा प्रोग्राम नहीं था, तो वो बेचारे हमेशा ऐसे आ जाते थे हमारे घर में अपने मित्रों के साथ, अपने भाइयों के साथ, 8 लोग आए थे टोटल। उस दिन मैंने पूछा था उनसे, चूंकि उनको पहले से हार्ट पेशेंट थे, शायद सबको पब्लिक को नहीं पता, उनके 6-7 स्टेंट लगे होते 7, तो मैंने ऐसे कान में पूछा कि क्या आपका सब ठीक चल रहा है, तो उन्होंने कहा डॉक्टर साहब अभी बाद में बताएंगे, तो ही वॉज ट्राइंग टू पोस्टपोन दैट। अब अगर किसी को 7 पेशेंट स्टेंट लगे हैं और उनकी वाइफ से बाद में पता लगा, उसे तो नहीं पता लगा कि उनको हार्ट अटैक हो गया, बेहोश हो गया, तो उनकी वाइफ ने बताया कि डॉक्टर साहब दवा आप ही खा रहे थे और इनके थोड़े दिन पहले शादी में दर्द हुआ था, इन्होंने इग्नोर किया। तो इससे 2 बातें सीखने को मिलती हैं। अगर आप हार्ट पेशेंट हैं तो आपको कम से कम इतना यंग मत सोचिए कि आप जिम करें, इतना यंग मत सोचिए। वो करते थे, फिटनेस फ्रीक थे, दुबले पतला रहना चाहते थे, उनको शो करने पड़ते थे, उनको दौड़ना पड़ता था, उनको एक्टिविटी मेंटेन करनी पड़ती थी, तो वो जिम बहुत करते थे। जिम शुड बी कॉन्ट्राइंडिकेटेड इन एनी पेशेंट ऑफ हार्ट, चाहिए कि स्टेंट लगे हो चाहे 7 लगे हो, नंबर 1। दूसरी बात आती है कि कभी भी कोई सिम्टम इग्नोर ना करें। हल्का सा छाती में दर्द हुआ, अगर आप हार्ट पेशेंट नहीं भी हैं तो भी आप सलाह लें। तीसरी बात आती है, उन्होंने 2 साल से दवा मेरी खा रहे थे, कोई चेकअप नहीं कराया मुझसे। बॉम्बे में भी चेकअप देखा, उनके सारे पर्चे, डायबिटीज मुझे सिखाने के लिए बता रहा हूँ कि मुझे डायबिटीज डॉक्टर दिखाते थे, हार्ट को दिखाते नहीं थे। वन शुड नॉट टेक इट लाइटली। एनी हार्ट पेशेंट, स्पेशली इन कोविड टाइम, हार्ट पेशेंट और नॉट हार्ट पेशेंट फैमिली हिस्ट्री, उसको रेगुलर चेकअप कराते रहना चाहिए। इसी से हम बच सकते हैं। जैसे या डांस करते करते हुए के को भी हार्ट की प्रॉब्लम पहले से थी, जिनकी डेथ हुई वो गाना गाते गाते। तो इन सब को हमको सीखना ही पड़ेगा। जब सेलिब्रिटी की मृत्यु होती है तो ये वाइडली चर्चित हो जाती है अखबारों में और मीडिया में, इलेक्ट्रॉनिक मीडिया में। इससे आम पब्लिक को फायदा ये होता है कि कम से कम कुछ सीखने को मिलता है। आपके अभिभाषण से हमें सीखने को हमें जो मिला, इसको इलेक्ट्रॉनिक मीडिया में या इसको प्रेस कॉन्फ्रेंस करके, आज की जो भाषण है, अमित मुंजाल हमारे साथ हिसार के आए हुए हैं, बैठे हुए हैं, डॉक्टर एस एन पाठक अपोलो से बैठे हैं, तो इसका एक छोटा सा प्रेस ब्रीफ बना के वी कैन गिव इट टू द प्रेस, स्पेशली द हाईलाइटिंग पॉइंट व्हाट अदर पीपल स्पोक। तो इससे आपको हमें हर चीज एवरी डे इज लर्निंग। तो आपको ये हमको सीखने को मिला कि केवल ये यूट्यूब और फेसबुक पे ना रह जाए, इसमें ऑल्सो गो टू द प्रिंट मीडिया। परफेक्टली ऑलराइट, सो प्लीज गो अहेड।
सबसे पहले तो नमस्कार विनय शर्मा जी, थैंक यू, आपने आके यहाँ पे हम सबको अपनी भाषण से विभाजित किया। आप जैसे लोग हमें प्रोत्साहन देते हैं तो बहुत अच्छा लगता है, क्योंकि डॉक्टर लोग हर जगह चाहे क्या हो अमेरिका हो हम लोगों को अप्रिसिएशन और प्रोत्साहन की बहुत ज़्यादा ज़रूरत होती है। हम काम अच्छा करते हैं लेकिन जैसे कि पहले के टॉक में हुआ कि लिटिगेशन हम अवॉइड नहीं कर सकते और लोग हमें समझ नहीं पाते कि हम दूसरों को भला करना चाहते हैं, उनको सिखाना चाहते हैं। जैसे डॉक्टर गुप्ता ने कहा कि एवरी डे वी आर लर्निंग समथिंग। So I'm very grateful for this opportunity. Yes, in front of all you esteemed cardiologists, maybe I don't have the expertise to, shed light on cardiovascular disease per se, but I'm an internist and a geriatrician. So I would like to share how geriatrics and cardiovascular disease impact each other. And fortunately, I'm in the academic field myself, so I try to help and educate my residents, my students, as well as my patients to just be a little more sensitive towards age-related cardiovascular disease manifestations, and that's what I'm going to focus about. So without taking much time, the objectives of my presentation, I'll talk a little bit about predisposing factors, age-related changes in the cardiovascular system, conductive system changes, how presentation and symptomatology are different in older adults. I do not like to use the word elderly because it sounds a little aged, like sexist and racist. So we in America, we are trained to be using as older adults because they're all adults, and just because they're old. TAVR is an equally towards the overall functional status. So I just wanted to point out, because this conference was more about TAVR and TAVI. So I just wanted to point out that there was no difference in the overall survival, at least when it comes to age, so patient-related poor cognition. So they'll have more myopia, their quality of life will be affected. So that is a constant discussion that happens.
Thank you.